Welcome to the Rehab Remix.
Where we break down the hottest topics in ortho and neuro PT to help you elevate your clinical game. We're your hosts, Dr. Lauren Tighe
And Dr. Lauren Young, bringing you practical insights straight from the evidence to your earbuds. You know what time it is? The mic is on, the vibes are right, and we are diving back in. This is where research meets real life and voices from the field bring it all into focus. Put your headphones on. It's time to remix.
Hey, everybody. We are so excited for this episode. Thank you so much for tuning in. We are your hosts, Dr. Young and Dr. Tighe here. We are going to talk today about to me, I would say, a topic that I really wasn't super familiar with in the PT space. But we're going to talk about migraines and physical therapy treatment and how that kind of works into our PT profession and our PT world, because we have an awesome guest coming up on our next few episodes following this episode here today. So let's quick talk about migraines. Dr. Young, do you want to give us just like a little bit of background on like our prevalence of migraines, things like that?
Yes, next episode, we're going to have Dr. Jimmy Pang on. He is like a migraine specialist. It was so impressive to chat, and I'm so excited for y'all to hear these things. I think migraines are a missing link or a missing piece that we're not talking about. Prevalence is extremely high. It is the leading cause of disability in our population. Most people are going to experience a migraine at least once in their life. It's about 14% of the population that is having migraines. Females tend to be more affected than males, and we'll kind of talk about why, or one of the reasons why as we move forward. But it's really common, and it can present in a lot of different ways. So there's hemiplegic migraines, which can be obviously terrifying because one half of the body goes numb. There are migraines that disrupt speech. They can cause dizziness. Again, from a perspective of a female, around the menstrual cycle, hormones can increase and cause migraines. And so you can have a migraine that is linked to a hormonal change or imbalance. During a menstrual cycle, I can think of a handful of people that when I've really gotten into their history, they've come to me with dizziness. I've got direct access. So I'm seeing them, within 24 hours of this dizziness beginning. A lot of the females, the first thing I ask is, are you close to being on your menstrual cycle? Because that hormone disruption, imbalance, influx causes this feeling of dizziness, off balance, nausea, things of that nature. Of course, we have the normal migraine, and this is a myth that we don't commonly talk about. Headaches don't have to accompany a migraine. So someone can have a migraine without the headache. They can have a migraine without the aura. That being said, I just think it's important to remember that when people are coming in with maybe neck pain or this abstract dizziness, we need to be asking about migraines. Do you have a history of migraines? What does that look like for you?
Yeah, I think that's such a great point, because when we think about migraines, and if you've ever interacted with somebody who's experienced a migraine or has, history of migraines, like migraines can really be a burden. They truly can. It is beyond pain. It can be debilitating in terms of like causing lost work days, reducing their quality of life. If they have children, they're not able to interact with their children because that migraine is just really, really debilitating for them. And so I think being able to identify that and asking some of those questions that Dr. Young just pointed out is really, really important. And especially to our female population who maybe doesn't know that they're experiencing a migraine. So like asking them questions to say, are you around your menstrual cycle? Asking them additional follow-up questions to get more information. Is it just a headache or is it a migraine? And then you think about the world that we live in terms of a lot more remote working. A lot of people who maybe don't have a long history with migraines, they might develop that from sitting at a computer all day, staring at blue lights, being under like bright lights for working. You can see in my background, my light is a little bit more dimmed because throughout the day, like I start to get a pretty bad headache. And so thinking about how debilitating migraines can be, this is why they matter, right? Because our goal is to get our clients and our patients back to doing what they love most, being able to participate in all of those life things that they enjoy because migraines take them out of that. And I think that's just really important to remember because this is something that really is a top cause of people living with a disability globally. And I think that's really, really important. And again, I don't think it's something that's talked about enough, especially when we talk about those statistics. Like, the statistics that Dr. Young just shared is insane. Like if we think about 14% of people, 14% doesn't sound like a lot, but when you think about it from a global standpoint, that's like 1.1 to 1.2 billion people globally. That's a lot of individuals. That's because we have so many people across the globe. So 14% is a large amount. And so I think just bringing this conversation to light more frequently will help it become more of a topic to at least identify in our clinical practice. It doesn't necessarily mean that you need to be an expert, but I think it's important to be familiar with those signs and symptoms so then you can refer to an expert in treating migraines from a physical therapy standpoint.
Yeah, I think vestibular migraines are another category. I didn't mention them previously, but vestibular migraines are really getting a lot of attention right now. We have a little bit more information. Those are going to present very similarly to a lot of these other types of migraines, dizziness, nausea, off balance. I can tell you, I'm not a migraine sufferer, but 2 years ago, 3 years ago, in high stress times in my life, I woke up and I was so off balance. I felt like I was walking sideways. I was really nauseous. Like my gag reflex was really sensitive. I remember waking up and being like, am I having a stroke? Like, what is happening right now? So the first time it happened, obviously I was nervous. I went to work and had some people do like a vestibular screen on me and we couldn't find anything. So I started to think, is this a vestibular type migraine or something of that nature? And it happened the second time. And again, periods of high stress. So I'm not somebody who has migraines. I don't have headaches. And then this happened to me. So it was really scary. And I think that's what a lot of people with migraines who present this way will tell you is the first time it ever happens, it's extremely scary. Another aside story, if you will, is I teach in a PT program and we were teaching vestibular. So I was doing an oculomotor exam on one of my co-faculty and I saw refixation saccades during smooth pursuit testing. I was like, well, that's weird. So then I did saccadic testing and she was overshooting and undershooting. And, I'm trying to play it cool because I'm teaching a whole bunch of students, but I'm like, what is happening right now? Like, these are central signs. And so at the time it was COVID, we were all in masks, and I real quietly said, "Are you okay? Your eyes are jumping." And she nodded, and we got done. Well, she is a migraine sufferer, and she mentioned that before she came to lab, she had kind of been feeling icky, and then it got better, and I was seeing her in the post-drone phase of her migraine. So she still had some, like, residual central signs because a migraine is a central diagnosis. If it is a chronic migraine is a chronic problem, which for her it was, it is considered a chronic pain syndrome, and it is a central sensitization. And so it is truly affecting your brain. And I was seeing those residual effects of the migraine just as I was teaching this skill. And so that's something that I like to point out too is you might see things that are look really sinister and you have to be able to differentiate, is this a migraine, is this a stroke, is this a brain tumor? There are some things that you have to pick out and be confident with knowing. And of course, to me, my risk tolerance is very low. If I have any question, I'm sending back to neurologist and I will let them determine if they want imaging or all of those other things. But you can work through your hypothesis of, is this a migraine or is this, something more sinister like a stroke? The HINTS exam, the brain PT, if y'all want to follow her on Instagram, go follow her. She has put out a couple of um, like posts about the HINTS exam and just what it is. And that's how in the emergency department, PTs, because PTs work in the emergency department, that's probably a whole conversation for another episode. But PTs in the emergency department will use the HINTS, it's HINTS exam to determine whether or not there is a stroke happening or if this dizziness is something that is not a stroke. And so that can be really helpful. Dr. Tighe, do you want to take us through what maybe the evidence says about what we can do as physical therapists generally to kind of limit or reduce the frequency of migraines for people who have them?
Before I forget, I wanted to also kind of touch on something that you said about differential diagnosis. So, we mentioned before, you don't have to be an expert in migraine care, but what we would encourage you to do is really hone in and fine tune your differential diagnosis abilities, because not only do you want to be able to identify those red flag, sinister type of pathologies, but you also need to be able to differentiate between musculoskeletal pathologies. And so, that is important because a lot of times people with migraines will present with a lot of musculoskeletal impairments like neck pain, cranial cervical, like musculoskeletal dysfunction, and to Dr. Young's point, some dizziness, vestibular impairments. So there's a lot of different systems at play here. So, really being able to fine tune your differential diagnosis abilities will be really, really important to be the best you can be in terms of treatment for these particular individuals. Whether that treatment involves you referring them to a specialist, referring them back to neurology, or figuring out a way that you can address some of those impairments if your specialty is MSK, if your specialty is neuro, but maybe not specifically migraines. So thinking about that, just wanted to point that out because I think what she said was beautiful. And I think it's really, really important to just continually fine tune those differential diagnoses skills. So I'm thinking about the evidence. So when we think about current research, there is a decent amount of research out on the correlation between migraines and physical therapy intervention. So there's growing evidence for exercise, such as like aerobic exercise or specific cervical region exercises and manual therapy specifically for those people who have migraines with headaches, because you don't necessarily like Dr. Young said, that can be separate. Like people have migraines, but that doesn't necessarily mean they have headaches. But when we think about headaches, we're thinking more about like cervicogenic headaches. So we can really kind of utilize some of those skills that we would utilize for someone who's coming in with cervicogenic headaches, similarly to someone who's coming in with migraine symptoms that are also giving them headaches as a result of those migraine symptoms. And so there are some clinical practice guidelines relative to cervical and neck specific exercises, and it does really give it a decent grade in terms of like those aerobic exercises and some of those migraine symptom relieving exercises. It gives it a grade B, which is pretty good when we think about the grading scales of our clinical practice guidelines. Anything that's really like an A or a B, like that's what we want to see, right? So that's telling us that those things can have a positive effect on this population. And I think those are some really easy things that we can incorporate, right? So again, even though this may not be an area that you have seen over and over and over again, or it's not your specialty, if you have that person walking in your door, you absolutely want to try to help them feel a little bit better by the time they walk out your door. Whether that is walking out your door because you referred them to a specialist, or you just said, hey, let's try this. Let's come back tomorrow or the next day and see how you're feeling. But something like a suboccipital release or something like gentle passive range of motion, gentle cervical traction, things like that, I think can be really beneficial, especially at that first visit, because when somebody's coming in to see you, they are looking for relief, like right then and there. And I think that just is in general, when we have people coming in with any sort of pain or debilitating symptom, that's what they're looking for. And that's also how you create buy-in. So you don't have to recreate the wheel. You don't have to come up with some magic trick or some magic potion to make them feel better. Use what you have in your toolkit from a orthopedic or musculoskeletal perspective.
Yeah, as Dr. Time said, you have to be good at being a differential diagnoser, if you will. That is, for clinicians who are listening to this who are a little newer to the profession, differential diagnosis was one of the courses that took the PT degree from a master's to a doctorate level, because we have to be able to differentiate these things. So being confident, knowing the basics. Dr. Davis, when he was on our podcast a few months ago, he said the people who are the best at what they do can do the basics well. And this is the foundation of being a good PT. You don't have to know how to treat migraines, but you have to know how to differentiate that headache or that what's happening from, is it cervicogenic in nature? Is it a migraine? Is it all of the above combining together. So, understanding those things is going to make you a better PT. We have more information coming next week and the week after. We're so excited for Dr. Jimmy Payne, his episodes. Thanks for tuning in to the Rehab Remix. We'll see you next time.
Bye.
Be sure to sign up for our newsletter linked in the show notes. You can find me, Dr. Young, on Instagram at NeuroElitePT. And Dr. Tighe, where can they find you?
On Instagram as well at LTigheDPT. Thanks for tuning in to the Rehab Remix, where you listen in and level up. We'll see you next time.